welcome everybody to Dr. Nisreen Rumman's talk about PCD in resource-limited settings, diagnostic challenges and potential options. Dr. Rumman is a pediatric pulmonologist in Palestine. After receiving her pulmonary training in the US, she started her clinical practice in Palestine and then was there challenged by the large number of clinically suspected PCD cases. And in 2015, she received an ERS short-term fellowship to learn more about PCD diagnostic at Southampton PCD Center. And since then, she's been an active collaborator in international PCD meetings and collaboration. And we are very happy to have her here on this topic as an expert. Thank you very much.
Okay, so first of all, thank you for inviting me to speak today about this topic, PCD in resource-limited settings, and to share with you my experience in setting up PCD work in Palestine. So we all know that PCD is an inherited disease, mostly as autosomal recessive, but we know that other forms of inheritance have been reported, like X-linked inheritance and autosomal dominant subtypes. And the global prevalence is about 1 in 7,500, according to the most recent publication. But since it is an inherited disease, we know that it is much higher in consanguineous populations. And there was a study from the British, Asian, Pakistani population that reported a prevalence of 1 to 2,200 because they had a very high rate of consanguinity. And these prevalence studies have mostly been done in developed countries. And the prevalence in developing countries may be even much higher because we know they have a higher rate of consanguinity. I don't really need to tell you about the clinical features of PCD, but just a quick overview that neonatal respiratory distress is common. It's in 82% of cases, chronic wet cough and chronic nasal congestion in almost all of the patients, chronic and recurrent otitis media in 92%, pneumonias 80%, and laterality defects in about half of these cases. So you can see that the symptoms and signs are really non-specific. And this has led mostly to late or even no diagnosis of PCD. And this is because of many reasons, especially poor knowledge of the disease. We know that PCD is not as famous as cystic fibrosis among the general practitioners and general pediatricians. So they have poor knowledge about the disease, so they will not really think about it. And the other reason is that symptoms are so common that they are frequently overlooked, especially in a busy ENT or pediatric clinic. So in my country, general pediatricians may see 30, 40, or even 50 patients a day. So there's no really time to dig deep in the history and to see how many times the patients have come for respiratory symptoms. So they will not really think about PCD and they will just treat the acute presentation. And the other reason is that symptoms are chronic and they are not recognized as abnormal. And I see this in my clinic. I have families, when I ask, is the child coughing? They would say no, and the child will be coughing in front of me in clinic. And when I ask, so what's this? And they say, no, this is a normal cough. So it becomes like a white noise for them. They get used to it. Another symptom that's really overlooked is the nasal congestion, when they are very congested and they have nasal speech. So the parents get used to that voice of their children, and they don't recognize that they have nasal speech. It really requires someone who's listening to the child for the first time to really recognize that they do have significant nasal speech. And the other point leading to late or no diagnosis is the difficulty in the diagnosis itself, because we don't have a gold standard test. None of the tests available can 100% diagnose all cases. And especially in resource-limited settings, there is lack of resources and testing. So all of these factors really contribute to either late or even no diagnosis. So since the symptoms and signs are really non-specific, so how do we know which patients to think of PCD and which patients to refer for testing? You may be familiar with the PICADAR score, which is the work done by Laura Behan and colleagues. It's a clinical predictive tool to determine the likelihood of having PCD, and it applies to patients with persistent wet cough. And they had 7 predictive parameters, which are full-term gestation, neonatal chest symptoms, NICU admission, chronic rhinitis, ear symptoms, situs inversus, and congenital heart disease. So for each of these parameters, you assign a score, as seen in the table here, and then you calculate the total score. And they found that a cutoff score of 5 points had a really good sensitivity and specificity, 90% sensitivity and 70% specificity. And the use of this score can help you increase the number of actual diagnoses. But there's a caveat that you really can miss cases, and you can't depend on just this score. You need to use your clinical judgment, and you're seeing the patient several times to be able to discern which patients to refer for testing. So we talked about the clinical presentation, and this is the first step in suspecting diagnosis. And a really useful tip is to always keep a high index of suspicion. You always need to think about PCD, especially when the child comes more than one time with respiratory symptoms, upper and lower airway symptoms. And another important point is really to educate your colleagues, especially educate your neonatologists, because they are the first ones who encounter those patients in the neonatal ICUs. And the neonatal period is really a very good window to catch these patients, because once they are outside the NICU and they are under the general pediatrician's care, general pediatricians see a lot of patients, especially in the first 1 or 2 years of life, with recurrent upper and lower airway symptoms, especially the infants and young children who go to daycare. They always have recurrent respiratory upper viral illnesses, so they can really be missed here. So the neonatology period is really a good window to catch those cases. And of course, you need to educate the general pediatricians to dig deep in the history, especially for the ones who keep coming to them with symptoms. And also the ENT doctors, you need to educate them. They also see a good proportion of these cases with recurrent sinus and ear infections. Another specialty that is really sometimes we forget about is the obstetric and gynecology colleagues, because they can pick up patients in 2 different settings. In the prenatal settings, when they do the prenatal detailed ultrasound, if they find for example, congenital heart diseases or situs inversus totalis, they really need to think about PCD and maybe alert the neonatologists about this possibility. And the other window is when they are faced with adult infertility, and this is a good window to screen the cause of infertility and to ask about respiratory symptoms. If they do find respiratory symptoms with infertility, this should ring a bell that they need to think about PCD. So it's a very important point to educate your colleagues, especially in your resource-limited settings, because the clinical features is really an integral part of your diagnostic pathway. So these are the 5 tests that we do for PCD. I'm sure you all know all the 5 tests: nasal nitric oxide, high-speed video microscopy analysis, transmission electron microscopy, immunofluorescence, and genetics. And as you know, all of these tests are expensive and they require very experienced personnel. And you need a lot of equipment and complex, sophisticated equipment that are also expensive. And many of these tests are only done in research centers. So let's discuss each of these tests and try to find solutions for you if you are really working in a resource-limited setting. First of all, the nasal nitric oxide. You all know that we have two devices for measuring nitric oxide. These are the chemiluminescence analyzers, and they are the fancier and expensive big devices, but they are stationary. You cannot move them from one place to another. They are more accurate. And I'm sure you are familiar with the technique of testing, where you put an olive in the nose and you ask the patient to breathe against resistance, which is the ideal method to do the test. And then you collect the air from the nose and sinuses, and you get the result of nitric oxide. Now, in resource-limited settings, these devices are expensive. You may not be able to have them, but a cheaper option is to have the electrochemical analyzers. And I used to have the Niox Mino device, and now it's out of the market. It's not manufactured anymore, but it's replaced by the Niox Vero machine. And these devices, although they are less accurate, but they have several advantages, that they are cheaper, and it's a good place to start if you live in a resource-limited setting. Another advantage of these devices is that they are portable. So this is me carrying my Niox Vero machine here with my laptop. And I go to several cities in Palestine. I do clinics in Hebron, in Bethlehem, in Jerusalem, and in Ramallah. So I see patients in all these places. And sometimes I get patients referred to me from Gaza. And we have a unique political situation in Palestine, and that's why these devices come in handy, because I can take them to all these clinics where I go. In our setup, the patients don't prefer to travel between cities because of the political situation and the conditions here. So it's easier for me to go to them rather than them coming to me. And even in well-resourced countries, if you have outreach clinics, these devices can also be useful because they are portable. You can just carry them with you wherever you go. So the second test is the high-speed video microscopy analysis, where you assess the beat patterns. And for doing this test, you need a fresh sample. So you ask the patient to blow their nose, and then you get the ciliary sample using a brush biopsy and a brush sample. And then you prepare your slide in a special medium, and then you look under a special microscope with a special setup. You record the movement of the cilia real time, but then you can replay the video at a slower motion, and it will enable you to detect all the beat patterns. This setup is from Southampton, where I did my short-term fellowship, and this is the setup that they use. So when I was there, I was thinking, now I was introduced to all these fancy equipment. Now I'm going to go back home to Palestine and start diagnosing my patients. I will not have this setup. So we did an experiment, actually. I will tell you about it in a minute. And this is the thing that you see on the high-speed video microscopy. So this is actually my cilia. Obviously, I don't have PCD. My cilia is moving nicely. So you can assess the coordination. You can assess the backward bending, the forward stroke, and then also the movement of the particles. So you can assess also the beat frequency and the beat pattern. So this setup is probably expensive, but more than the expense or the cost, it's really the expertise, because you don't just see immotile cilia in primary ciliary dyskinesia. There are many cases where the abnormality is very subtle, and you really need a lot of expertise to be able to discern these subtle abnormalities. So I don't expect you to read this poster. I just wanted to highlight the thing I mentioned earlier, that during my fellowship at Southampton, I thought, when I go back to Palestine, can I use a simple light microscopy to detect those abnormal patterns? So we did an experiment where I looked at the samples that came to the lab using a light microscopy, just a simple microscopy without any software, without anything. And the PCD scientist at Southampton looked at the same samples using their setup, the fancy equipment. And then I was, of course, blinded to the results. And then we compared the results. And you can see here from the drawings that there were two normal samples, but I was able to pick up one. And there were 7 abnormal samples, but I was able to pick up 3 out of the 7. And actually, those 3 were the ones that were immotile and static. So it was easy to see under light microscopy that they were not moving. But you can see if we depend only on light microscopy, you could miss a lot of cases, because in many cases, it's not just immotile or static, it's the other subtle abnormalities. And also in terms of decision making, the PCD scientists here had 15 cases where they wanted to repeat the test, but my outcome was different than theirs. I wanted to repeat in 8 samples. I diagnosed as abnormal in 1, and as normal in 2, and 4 as insufficient. So you can see that the outcome may be different. So if you are interested in having microscopy at your center or in your country, be careful that you will not be able to pick up all cases, and you may miss cases if you depend only on simple light microscopy. So we talked about the clinical aspect, we talked about the nasal nitric oxide, and we talked about microscopy. And these 3 aspects can actually give you justification to start your basic treatments, especially because the treatment that you're going to give does not really harm the patient. So you will give mainly airway clearance therapy, which they need anyway, because they are presenting with chronic wet cough and sputum production. So they need to clear their airways anyway. And the other part of the treatment, you may choose to give antibiotics for infection, which they will need anyway. But you cannot tell the parent or the child or the patient that you do have PCD. You still need a confirmatory test. And according to the ERS and ATS guidelines, a positive diagnosis can only be made with supportive clinical history and either a hallmark transmission electron microscopy defect or pathogenic mutations in PCD genes. And it's the confirmation of the diagnosis is not just important for us or for the family. It's also important if you want to include your patients and enroll them in international projects, because you need to have specific standards and confirmed diagnosis to be able to enroll them in these studies. Now, the third test is electron microscopy. And, it needs a huge infrastructure with the huge electron microscope and expensive equipment. And you can see that with the electron microscopy, you look at the ultrastructure, the normal is 9+2. And you can see the image on the right here. This is how the cilia look under the electron microscopy. And these are some of the ultrastructural defects that you can see in TEM. So this is the normal, and this is the one with outer and inner dynein arm defects. This is outer dynein arm defect without inner. This is inner dynein arm defect without the outer. And this is the microtubular disorganization. And initially, there was no consensus on what constitutes a diagnosis of PCD based on the electron microscopy. And different centers were really reporting different reports and different terminology they were using. This led to the development of an international consensus guideline for reporting the abnormalities seen on electron microscopy. And this work led by Amelia, they classified the abnormalities as class 1 defects, where you see hallmark defects, and this confirms the diagnosis in a patient with symptoms. But then class 2 defects are more difficult to recognize. And this indicates a diagnosis in a patient with symptoms if consistent across more than one sample or after cell culture. And also it needs to be consistent with the other test results. So class 2 cannot be diagnostic by themselves. And actually, this group did not reach consensus on some abnormalities. For example, the isolated inner dynein arm defect and other abnormalities, they did not reach a consensus on. So you can see how hard it is, even for the transmission electron microscopy, which is actually considered a confirmatory test, but still hard even in well-resourced countries where you do have all these fancy equipment. And another caveat is that we know that 30% of PCD cases have normal ultrastructure or on TEM. So you really cannot just depend on electron microscopy. So the fourth test is the immunofluorescence using labeled antibodies, and you need also fancy equipment, this confocal microscope, which is again expensive. And it's not just the cost. Again, it's not just the cost in all these equipment and all these diagnostic tests. It's the expertise. To get really nice images like these, this process needs a lot of expertise to get the staining right, to get the antibodies, to get these beautiful images. This also needs expertise. So for resource limited countries, you don't just look at how much the money it costs to buy the equipment. You need to look at whether you have the correct personnel to have all these testing done. And the fourth test is genetics. We know that there are many genes involved in PCD. We have about 50 or even more now, PCD genes. Some will be involved in celiogenesis, and some will be responsible for the outer dynein arms or the inner dynein arms or the microtubules. So we have so many genes involved. But we all know that the pathogenic mutations in non-PCD genes only cover about 65 to 75% of PCD cases. So that's why even with the full genetic workup, you may still miss cases and not diagnose them with PCD. So you have to be careful. So after discussing all these tests and looking at options for resource-limited countries, you can see that the diagnosis can be very challenging, even for well-resourced countries, and even more for resource-limited countries. This is why I want to stress the importance of collaborations, because they are very critical if you really want to confirm your patients and to participate in international studies. So you may be able to start a service in a resource-limited country, but you still need this international collaboration. So I want to share with you my experience in Palestine over the last few years. In Palestine before 2013, I did not have any of the tests available, and I was faced with so many suspected cases, but I had no way to confirm the diagnosis. This is why I applied for an ERS short-term fellowship, and I went to Southampton for 3 months. I learned about all the diagnostic testing, and then I started collaboration with them and also with UCL in London. So in Palestine, through this collaboration now, when I have a clinical suspicion, high clinical suspicion, I do local testing with nitric oxide. And if it's low and the clinical suspicion is high, I go ahead and send a sample like a ciliary brushing and put it in glutaraldehyde and just ship it to Southampton. And because I have several families with more than one affected or more than one suspected case, we chose to do like an index case from each family, because eventually I don't want to overwhelm the diagnostic service in Southampton. So I will choose one index case from each family. I will take the sample and ship it. And it's easy to take the sample and put it in this glutaraldehyde because it's stable and it can stay for several days in the mail. And then if it comes back positive, I will screen the symptomatic siblings and relatives with nasal nitric oxide locally. And I will also take blood sample from the family and send it for genetics to University College London, where they were doing the genetics for us. So this is a complex algorithm to go through, but I just wanted to highlight one thing here. We do have the European algorithm for diagnosis, and we have the American algorithm for diagnosis. And if you practice in a resource-limited setting, you probably cannot follow any of these algorithms because you will not have all the resources. So you may end up creating your own diagnostic algorithm. And this will help you with diagnosing more patients. And actually, in our setup, we did not follow any of the ERS or ATS guidelines because in terms of order of the testing, because the choice of my testing was really depending on the available resources at the time. For example, we had patients going to genetics without even nasal nitric oxide, because sometimes I would run out of the supplies, the disposables for the nitric oxide, but the patient has a really positive family history or positive clinical high strong suspicion. So I would proceed to genetic testing or genetic testing before electron microscopy. So we really didn't follow a specific order of testing. So we had about 464 patients with clinical history suggestive of PCD. And out of those, I performed nasal nitric oxide measurement in about 350, and electron microscopy was done in 184 and genetics in 99. And we did have a good result, positive testing in a good percentage of those. So we have a total of 80 confirmed cases according to ERS and ATS guidelines. So they either had hallmark electron microscopy abnormalities or two mutations in two non-pathogenic mutations in one of the PCD genes. And we still have about 105 cases that are still awaiting to be confirmed, but they are highly likely to have PCD because they have a really strong clinical suspicion and maybe situs inversus as well, and also low nasal nitric oxide. So that's a huge number of cases in a relatively short time. And out of those who had electron microscopy, the 184, the electron microscopy was positive with hallmark defects in 50. It was normal in 98, and it was inconclusive or still pending in 36. And we did proceed to genetics in each of these categories, because even in the ones that had inconclusive or pending results, because of if the clinical suspicion was really strong, we proceeded to genetics. And for the ones who had positive electron microscopy but had siblings and cousins who are suspected, the concept of the index case I pointed out earlier, we did proceed to genetics immediately, because once we know the mutation in the family, those siblings and cousins can be tested through targeted mutation testing. And we did have a good percentage, we did pick up a good percentage of cases. And this slide shows you the electron microscopy correlation with genetics. So we had outer dining arm defect in 17 cases, and these are the genes that we identified in those cases. We had ODA, IDA defects in 12, and these are the genes we found. And the most common TEM defect was microtubular disorganization and IDA. It was in 19 cases. And the most frequent gene was CCDC39. This is the most frequent gene in our cohort. And you can see here that we had many cases with positive electron microscopy, but we haven't identified the genes yet. So we really have a good chance of gene discovery here, more than one gene, because these are more different electron microscopy ultrastructural defects. So there is high potential for new genes here. Now, the mean age in our 80 confirmed cases was 11 years. Females were about 40%, and almost all of them had consanguineous parents. The BMI and lung function was very variable in the cohort, but you can see that it was already impaired in a good percentage of them. And the nasal nitric oxide was definitely low in all of the confirmed cases. The clinical features in our cohort was really similar to the international cohorts with some variability. For example, neonatal RDS was present in about 80%. persistent wet cough, 95%, rhinosinusitis, 95%, ear disease or hearing problems in 75%, situs inversus totalis in 42%. And interestingly, finger clubbing was seen in about 20% of cases. And this was a little bit surprising because it's not very common in international cohorts. And I believe the reason is that our patients, the lung condition is really bad, and they have a lot of suppurative lung disease. And congenital heart disease was present in about 10%. And these are just some of the pictures that seen in my patients. Really bad lung disease, bad bronchiectasis, nasal polyps, really bad sinus disease, and clubbing. So these are the genes that we identified in our cohort, and this graph shows you the distribution of the mutations. You can see that CCDC39 was the most common, and interestingly, 100% of the variants were homozygous, and this reflects the high consanguinity. So now that we know the causative mutations in most of these families, this will help me to do future targeted testing locally, because we know these families, we know the mutations now. So how has this project and this collaboration helped me? Now, if I am faced with a new suspected case of PCD, I look at the family history. If there is positive family history, I can now do targeted genetic testing for that specific mutation in the family. So I go back and see what mutation the family had, and I collect blood and just send it for this one specific mutation. And as I told you, because they are all homozygous, so it's only one mutation that you are testing for, and it's at a cost of about $50. So with $50, you can actually confirm a diagnosis of PCD. So far, after we characterized the cohort I told you about, I have done 29 local testing, local targeted mutation testing, of which 14 were positive. 7 had CCDC39, 1 had CCDC40, 3 had RSPH9, and the others had limited numbers. So for just the cost of $50, I was able to pick up all these 14 cases and confirm the diagnosis in them. And this really gives a lot of advantages. For example, you can have a quick diagnosis, sometimes within 2 weeks of my encounter with the patient. So I would see a patient, and if they do have a positive family history and they have a good clinical suspicion, I would collect the blood on the same clinic visit, and I would send it to the lab. If the probe that is used for this mutation is already available in the lab, they can give me the answer in 2 weeks. And this is a really very, very quick diagnosis. The other point is that I'm diagnosing patients at a younger age on my first clinical suspicion. Because when you're a clinician and you get patients with recurrent respiratory illnesses, sometimes it's not easy to think about PCD from the first time. So you can maybe tell the parents that you're suspecting, but let's wait, let's see if they have more clearer symptoms. But here, because it's a really low cost and you already know the mutation in the family, they can just pay this $50 and take the sample on your first clinical suspicion, and you can diagnose them early instead of keeping, going back and forth to clinic, waiting for them to develop more clear symptoms. And you also save resources and money, because if you don't test for this mutation with the $50 now, you would think about cystic fibrosis, think about immune deficiency diseases, and you may start testing for these, and you really waste the resources on the other expensive testing, where you can have it just $50 for a PCD diagnosis to start with. And even for the ones who have negative tests, it has been helping me with my clinical decision. So I say to the family, this is mostly not PCD, because I cannot give them a clear-cut answer, because I'm testing only for one mutation. So maybe they will have PCD, but a different mutation. But at least it's helping me, for example, to proceed to other testing for CF or immune deficiency or other causes of chronic lung diseases, even if the test is negative. And also, For the heterozygous siblings or cousins, I am able to reassure the family that this is mostly not PCD. And I will share this case with you. So MM is an index case who had positive electron microscopy showing ODA and IDA defect, and there was a mutation in CCDC 103. And this patient had a new sibling, and this sibling started to show some recurrent respiratory illnesses in the first few months of life. So the parents were worried, is it PCD as his brother or not? And, you know, he's just a few months old in the winter time, so it's normal to have recurrent respiratory illnesses. So, but I told them, why should we wait? We know your mutation. Let's just test the brother for that mutation. And I don't know how to read this, but I was told he was heterozygous for that mutation. So for this specific family, I could reassure them that the sibling does not have PCD. He is a carrier, but he's not affected because they are brothers. And most probably if he's affected, they will have the same mutation. So he's heterozygous, meaning he's carrier. So I followed this patient for several years after that, and he really did not show symptoms of PCD. So this has hugely helped the family to be reassured at an early age that this new sibling does not have PCD. So for the five tests that we have for PCD, what I have available now locally, I have the nitric oxide that I'm using to test patients. I didn't really invest in high-speed video microscopy analysis because if you have limited resources, you want to invest them in a confirmatory test and not a test that you will still be suspicious about the diagnosis. So I really invested in genetics, and we are doing that now after the clinical screening and the nasal nitric oxide. If we know the mutation, we are going straight to genetics. For electron microscopy and immunofluorescence, I put an X here because I know it's not going to be feasible anytime soon in my country, and maybe not at all. So that's why I wanted to stress the importance of the collaborations with international groups, because you still need to send some samples outside the country to do these tests. So in conclusion, despite limited resources, collaboration have facilitated accurate diagnosis of a large PCD cohort, as I just showed you, with high potential for new gene discovery. And local screening, either clinical screening and nasal nitric oxide, was able to identify likely cases that you need to proceed for further confirmatory testing. And identification of the causative mutations in certain families is facilitating local and much cheaper targeted mutation testing in suspected cases. So in summary, if you are in a resource-limited settings, there are several things that you need to consider. First of all, the prevalence of the disease in your country. How many patients do you have suspected of having PCD? Is it worth the resources? Do you have many cases that you need to start something in your country? Or if it's just few cases, you can just collaborate with one of the centers and they can help you with confirmation. So maybe you don't have to spend all these resources on this disease. So you need to have a rough idea how many cases you are faced with that are suspected to have the disease. And then you need to think about what tests can you secure locally. And you have to take into consideration not just the cost. So if you have a donation and someone giving you a lot of money to buy equipment, it's not just the equipment. You need the expertise, especially for electron microscopy and immunofluorescence and the high-speed video. You really need expertise to be able to discern all these subtle abnormalities. And a very important point to consider if you are in a resource-limited setting is to have centralized diagnostic services, which help you to save resources. And Bruna Rubo has done a lot of work on this. She has studied the service delivery models in different countries, and she compared them. I don't think that her work is published yet. She presented some of it in a poster at the last ERS meeting. But talking to her, she said that many of the international centers, many of the international groups, they said that they prefer to have centralized services because this will help you also to build up the experience of your team, because the more patients you see, the more samples you test, the more experience you get. So having centralized services really helps. So in your own country, if it's resource limited, you may want to talk to other groups and see if they already have started something with PCD. You may collaborate and start something centralized. And again, to stress the importance of collaboration with international experienced centers. So it's really important in your country, you need to know your population. Are they consanguineous? For example, is it possible in your country to have like what I'm doing, direct mutation testing, if there is like several members or cousins or relatives of a known family? So you need to consider all of these. And another important point is that you need to develop your own database, because you may find out that some mutations are more prevalent than others in your population. So you may develop your own population specific panel in the future. I know we do newborn screening for cystic fibrosis. Maybe PCD is still away from newborn screening, but who knows, science is developing quickly, PCD research is developing quickly. So maybe in the future, we will have a newborn screening for PCD, and then having a population specific panel like we have now for cystic fibrosis all over the world is really helpful. So keep your database, keep your mutations. You may find a pattern that will help you in building your population specific panel. So a final tip from me, never dismiss a suspected patient from your clinic, even if all testing is negative. And that's a really, really important point. And I will share a case with you that we recently diagnosed. RN, he's a 5-year-old boy that I started seeing 3 years ago. So in 2019, at that time he was 5, now he's 8.5. He had persistent runny nose, recurrent ear infections, chronic wet cough since infancy, and recurrent pneumonia. So really typical history of PCD. So I started doing some workup on him. We did immunoglobulins, which were normal. We did a sweat test, which was normal, and then a CT scan, which showed bilateral lower lobe bronchiectasis, and a flexible bronchoscopy, which showed no anatomical abnormalities, and culture was Haemophilus influenza. And then I tested him with nasal nitric oxide, and he was very low, 26 and 37 parts per billion. So I went again to send for electron microscopy, and it came back normal. And because of the suggestive clinical history and the low nasal nitric oxide, we did not depend on the electron microscopy. We proceeded to genetics, and we did not identify a gene. There was actually a possible candidate gene that they are still working on. But then in your review, just last month, we reviewed the whole exome sequencing again, and we found that he had a homozygous mutation for a known pathogenic variant in IL-21R gene, which causes immune deficiency, a primary immune deficiency, autosomal recessive, characterized by B and T cell defects and variable dysfunction in natural killer cells. And the patient is now being tested to undergo bone marrow transplantation. So we reached the correct diagnosis after 3.5 years, and it can be even longer for other patients. So really never dismiss a suspected patient from your clinic until you are able to confirm whether they do or do not have PCD. And finally, I would like to acknowledge everyone that made this work possible, especially Southampton Group, led by Jane Lucas, and UCL Group, led by Hannah Mitchison, and all the other collaborators and people who funded me with this work. Thank you so much for listening.
Thank you, Nisreen. Excellent talk. I think that's really opened our eyes up to the realities of PCD diagnostics in a resource limited setting. So now we're going to kick off the Q&A session. So please do write your questions in the chat. I think Yinting has 3 questions. So would you like to start off with one of yours?
Thank you, Katie. I just saw that Guillaume actually posted the first question in the chat box. I suggest we start with his question and comment. He wrote, "Thank you, Nisreen, for your presentation and your impressive work to take care of PCD patients in Palestine. Could you tell me how patients are referred in your unit all over Palestine? How doctors are sensitized to PCD diagnostic in your country?"
Thank you, Guillaume. This is a good question. So I'm the only pediatric pulmonologist in Palestine working on PCD. There are 2 others, but they are not really doing only pediatric pulmonology. They see general pediatrics, but I'm the only one who works on PCD. So any suspected patients by general pediatricians, even by adult pulmonologists, will get referred to me. They all know now that I'm working on this collaboration. I also, the slide that I showed you about educating your colleagues is really very important. What I did when I came back from Southampton, I went to every city in Palestine and I gave a talk about PCD to pediatricians, to ENT doctors. I repeated the same talk maybe 20 times. So really, I educated them that I'm doing this work, I'm diagnosing all these patients, you need to refer these patients to me. So that most of them and all over Palestine know that I'm doing this work and they refer all the patients to me. So I educated them, I told them about all the symptoms and signs that they need to look for. I even talked to gynecologists and obstetricians. So they all get referred to me. I'm the only one doing this work in Palestine.
Thank you, Nisreen. Maybe also the first part of his question, could you tell me how patients are referred to your unit?
So that's how they are referred. So they just give me a call. They all know my number. They just give me a call and they say, we have suspected cases. And I said, just send them. I will test them. I will take a clinical screening and I will do the nasal nitric oxide. And if they are highly suspected, I will go ahead and take a sample for electron microscopy. And again, if I do find a positive family history, because they are all related, I can go ahead immediately, and instead of sending for electron microscopy, I would send directly to genetics.
Great, thank you, Nisreen. And so for no more questions at chat box, so maybe, no, Monica has a question. Katie, would you like to? Yeah.
Yes, so Monica says, superb presentation, thank you. How did you accomplish funding for the genetic testing? Who pays for what in the Palestinian healthcare system?
So the genetic testing that was done for the cohort at UCL, the funding came from, let me just show you it. We applied for a grant with Jane Lucas through Southampton, and it was this asthma allergy information research. Can you see the screen? The AAIR.
Yes.
So we got funding for testing the cohort, the initial cohort from this resource. I got funding to from Circassia. Now it used to be called Aerocrine, I think. It was Aerocrine and now Circassia. They gave me the initial nitric oxide testing machine, the Niox Mino. So I used it for some time. And now the genetic testing is covered by the patients themselves, because if I do targeted mutation testing, it's only $50. So the families would pay for that. If not, and we want to proceed for whole exome sequencing, there's no funding at the moment. I still have about 40 families that do need whole exome sequencing, and we are trying to secure funding for those. But for the ones that I'm doing only targeted mutation testing, the families are paying for that. And for the Niox Vero machine that I have at the moment, I actually bought it out of pocket. So I'm doing the test myself.
Thank you. And Tugba says, thank you, Nisreen, for your great talk.
Thank you. You probably have also some limited resources in some of the centers in Turkey. Is that right, Tugba? You are probably facing some of these challenges.
Yes, yes, it's true. It's also very difficult for us. We don't have high-speed microscopy in every center. We can only do genetic testing in our hospital in Gazi University.
Can you do electron microscopy?
No.
Yeah.
Some years ago we can do, but for 3 or 4 years we couldn't do electron microscopy. We only have genetic testing.
I think the whole world is moving towards genetics more and more. I mean, we cannot say that electron microscopy or high speed are not going to be useful, because sometimes you still need a functional test, especially for the new genes, because you cannot tell whether these are pathogenic mutations or not. So you need, like in cystic fibrosis, even if we do have genetics, the sweat test, which is the functional test, is still the gold standard. So I think it's the same with PCD. If you have a new gene and new mutation, how can you tell that it's pathogenic? So you still need the functional tests, the nitric oxide and the high-speed video microscopy and the ultrastructural defect to see if there is any correlation. But yes, we are depending more and more on genetics.
Great. Thank you for your input, Tugba. And actually, this now leads to one of my questions, and also the last case that you presented, Nisreen, about the boy that you then sent to whole genome sequencing. So from the case of this last patient, is this now your usual process of someone who tested for genetics on the first round with maybe a negative result or maybe a variant of unknown certainty, or do you then proceed to test him with whole genome sequencing?
And no, for this specific patient, so he was one of the cases that were sent to UCL to do the genetic testing, and they did the whole exome sequencing, and they didn't find any PCD gene, but they were thinking about a candidate gene, and especially that the patient had a low nasal nitric oxide and a high suspicion on clinical basis. So I was really convinced that this child has PCD and we do need to find a gene. But when they told me there's no gene, I said, can you look at the whole exome sequencing again? Maybe it's not PCD. So they actually sent me the file for the mutation, and I asked our geneticist to take another look at the whole exome sequencing, and she picked up the immune deficiency gene. And what I learned that at UCL with the whole cohort, they mainly focused on PCD genes. They were looking for PCD genes, so they didn't really think about other possible differential diagnosis. But for this patient, because I was struggling with his management, he was really bad, and I wanted to know what's happening. So I asked to take another look at the whole exome, and they did find this mutation. So now, after finding this, I contacted Hannah at UCL again, and I said, for the ones that we didn't find genes, can we take another look now at the immune deficiency genes, because we were not paying much attention to the immune deficiency genes at the beginning. So I think we are going to review now the ones without diagnosis, without a gene, and maybe we can find. And when you do a whole exome sequencing, again, it's always recommended that you every few years you revisit your analysis, because new things come up and new techniques come up. So I think it's already recommended that for whole exome sequencing, people tend to go back and look if they find anything else.
Yes, indeed, that's a good point. Thank you.
Thanks, Nisreen. So I had a question about collaborations. So you said these are super important. what advice would you give to somebody who was or who wanted to reach out and make collaborations? How would they go about doing it from a resource limited setting?
So I think, first of all, you need to identify the people who are doing the work on PCD. The way I find out about Southampton, I just Googled them. I just said, this wasn't back in 2013. I just said, Googled primary ciliary dyskinesia research. And then at that time, I found Jane's name, Jane Lucas, in many of the papers. I just emailed her. I just contacted her and said, I have this situation. I have so many patients. I don't know what to do. And she said, we can help. And I started sending her the first sample, then the second sample. And then she pointed out the conferences that they were doing. It was Best Celia at the time, I think. So I joined the first conference in Athens. It was one of the Best Celia conferences. And then I got to know the people, all the group that are doing research on PCD. I started coming to these conferences, and then I joined the Coast Action BEAT-PCD, and I attended all of the conferences. So you get to know people more and more when you attend these conferences. And I'm sure if people are already on this group listening to this talk, they already know who to contact.
Thank you.
Thank you. Nisreen, maybe one of my questions, if there aren't any questions in the chat box. Now it's actually like a follow-up question of Guillaume's first question, how you educate all the experts or pediatricians and GPs all over Palestine. That's what you mentioned already. But is there then some kind of workshop or regular follow-up on that in information of all those treating physicians to keep them updated? Also, like, and how do you do this? Like every 2 years, or how do you make sure that also new generation of physicians are educated on PCD?
Great. So I'm affiliated with the medical school, and we get students coming to our hospital where we do clinical training. So I always make sure to give this talk to them. So when they graduate, when they are in the practice, they already know about PCD. I also teach residents at the hospital, so I give them this talk maybe every couple of years, because they spend 4 years in the pediatric residency. So I make sure that every generation at least heard the talk once. And we do have local conferences in pediatrics here. We haven't done any for the last maybe 2 or 3 years because of COVID, but we used to do them annually. So I try to also have a spot to talk about PCD in these conferences. And we also have a WhatsApp group for pediatricians all over Palestine. So whenever I publish anything, or whenever there is new guidelines published, I always post them to these WhatsApp groups. So they are always updated.
Thank you. That's excellent. That's a lot of effort, but I'm sure all those colleagues really appreciate what you do. Any other questions from the audience? Okay, then maybe one more question from my side. Now, because you are the only PCD physician in Palestine, and you travel all across the country, how do you set up all those consultations for your patients that are all across the country? Do you see them regularly every 3 months, or only when they think they need a consultation and set things up with you? How is all this organized?
So because I do the clinics in different settings and different cities, and the system, the electronic medical system is different in each place. So I try to keep a folder on my own laptop where I keep all these patients, regardless of which city I see them in. So I have all the data on my laptop. And for the management part, I always advise them to come and see me every 3 months, but not all of them will, because, you know, they have to pay out of pocket for these consultations. I don't work with the governmental hospitals, so they are not covered under a national insurance. So they actually have to pay for these consultations. So sometimes they will come later than 3 months, and sometimes even more. But I try to, I give them all my phone number, my private phone number. So I tell them, if there's anything, you can send me a message. I reply to their questions on WhatsApp. And if there is a really need for them to come to clinic, I will tell them, you need to come. You cannot solve this on the phone. So I try to be available for them whenever they need me.
Thank you very much. So your WhatsApp must be like a hotline for both physicians and patients. You're certainly very busy. So thank you very much again for being our expert talker today. Okay, then maybe just one final question from my side. Now, looking back with all your experience and how you set up things since 2013, would you, now with all your experience, would you do, or would you have done anything differently, or setting things up differently or earlier?
I don't think I would have done things earlier, because you know, it's not easy to do all this. And actually, many of the work I do, I don't have funding for. So several conferences that I attended were out of pocket. I don't think I would have done things earlier, and especially with COVID, you know, things were delayed a lot. Whether I would have done it differently, I don't know. It just depends on the resources available at the time. I couldn't change anything, actually. It's just the way this disease has a lot of needs a lot of resources, a lot of experience to build. So I don't think I could have done things differently. I tried my best to reach out to people, to ask for collaborations, to know more about this disease, to participate on all these conferences. And actually now many of my patients are already in international projects. And we are now publishing our cohort, hopefully soon. I don't think I could have changed anything.
That's great. Thank you very much, Nisreen.
Thank you so much for having me.
All right, Katie, shall we then proceed to our final information?
Yes, just a few announcements before everybody disappears.
Yes. Let me share this one.
Oops. So if you could just fill in the Padlet for us, please. It'll literally take a couple of minutes, and it really helps us for shaping sessions in the future. There's the joint BEAT-PCD and ERN lung annual meeting, which is happening on the 3rd of September. It's in person in Barcelona. And if you scan this QR code, it will take you through to how you can register for it. Just a pre-warning before we send out an email, we're looking to do a physiotherapy article in Breathe, and are looking for some early career researchers as volunteer authors. So watch out for an email about this. And we're super excited to announce our next session on the 13th of July. So we have Lynn Schofield, who is a physiotherapist in PCD. So we'll circulate some emails about that shortly.